All right, I'd now like to introduce Dr. Rolando Barrios. He's the Senior Medical Director for the BC Center for Excellence in HIV/AIDS. Dr. Barrios has spent the majority of his career working in leadership roles within the BC CFB and Vancouver Coastal Health. And
Thank you,
Dr. Barrios,
Valeria.
oh, go ahead.
Can you hear me well?
Yes.
Thank you. And thanks to Julio, Bob, and Mike for the remarks. I think it's been a journey for sure. I also like to thank Elder Glida Morgan. She certainly rounded up all what we do, or all we did over the last while, by calling it a virtual circle, which is essentially what we have done, and by bringing us together for the healing of our people, which is focused on the people living with schizophrenia or schizoaffective disorders. I'll be asking Valeria to move my slides, so please go next. I have nothing to disclose, so that shouldn't be an issue. So next, I'll give a quick outline here. I'll review the science, not in depth, because I think you already know it. I'll talk a little bit about the quality improvement journey and what have we accomplished so far, and at the end, a little bit of a summary. So the next, please. Quite often, the evidence for a particular medical intervention already exists, and if you recall, about 11 months ago, we discussed the need to optimize treatment of schizophrenia and schizoaffective disorders based on the evidence that is clearly outlined in the guidelines for the pharmacotherapy of schizophrenia in adults. And this treatment optimization of schizophrenia focused mostly on the objective of an adequate clinical trial in both dose and duration between 4 and 6 weeks, and a complement pharmacological treatment with psychoeducation. And for those who are diagnosed with treatment-resistant schizophrenia, clozapine being the only option, or the option that could provide them some control of the symptoms. Next, please. During the opening of our collaborative about 11 months ago, we learned that most of the clozapine initiation was happening in acute care settings. This in part was attributed to low patient acceptance, limited training, and support to our clinicians in community settings. We also recognized that to close this gap, we needed to change the current system, be more proactive, involving clients and families, and also saw the opportunity to use the model for improvement as a tool to drive the change in the system. Next, please. So if you recall, this was part of an artwork that was developed during our presentation, but back in June 2021, we met for the first time and learned about quality improvement. However, Drs. Harish Neelkant and Randall White and I have been working at least 3 years before in planning for this project. I was very impressed with Harish's commitment to improve quality care and the support and expertise brought by Dr. Randall White. Next, please. At the time of the launch of this project, I indicated that quality improvement is a journey of small steps. We didn't want to shake the system. There was not a huge change happening from one day to another. The next one. We needed to do some basic measurements and metrics that will help guide and help us to assess our progress and identify areas that needed improvement. Next. And to use small test of changes, also known as Plan, Do, Study, Act, or PDSAs, to achieve our aims. Next, please. Using the model of improvement, defining what we wanted to do and how we would know if the results resulted in improvement, we set our aims, and Bob has already stated them clearly. Next, please. We wanted to ensure that not adherent clients with schizophrenia or schizoaffective disorder were offered depot injections. We also wanted to ensure that clients diagnosed with treatment-resistant schizophrenia were offered clozapine, and appropriate clients who needed clozapine could go titration in the community. Next, please. Next. So we have a plan and collective effort, and that was using the structured learning collaborative model as depicted in the left side of this slide. Teams participating in a series of learning sessions and action periods. Bob had already mentioned, but it's worthwhile to stress that there were 17 top learning events delivered to date, 11 teams enrolled, 17 physicians, 20 participants overall. 40% of enrolled participants and 71% of enrolled psychiatrists attending the events. That's a very high rate of attendance as compared with other similar events. And out of this, 90% of the participants strongly agree that session content was relevant to their practice. And 80% strongly agree that session content enhanced their participant knowledge. Next one, please. And these are some of the numbers that we saw in this process. And if you recall, we started in June, but it was not until September that we started seeing some numbers. And the trends are increasing. Here we have the number of depot injections started, and this is a cumulative number. And as you can see that it's trending in the right direction. Cumulative depot injections increased from September to April. Next, please. Similarly, the number of clozapine starts started increasing or start increasing from September to April 2022. Next, please. The next few charts are a bit busy, but it really shows a little bit of the reflection of what Julio was talking about, the 90-90-90, which in the HIV world refers to 90% of people diagnosed with HIV, 90% on treatment, and 90% achieving viral load suppression. So if you look at this number and focus on the last the last column, the 3 bars, you'll see that about we have increasingly seen the number of people who were offered depot injections. So about 87 clients were offered depot injections, and about half of them, 55%, were offered the injections, and about 60% of those who offered the depot injections actually started the depot injections. Next one. Similarly, treatment-resistant schizophrenia clients were offered clozapine, although we didn't do as well in this area. If you again focus on the last side, you see the increased number of people that were deemed to be treatment-resistant schizophrenia, and also look at those who are being offered clozapine and the number of those clozapine starts. However, there is still a gap between clients diagnosed with treatment-resistant schizophrenia and those suitable for community start and being offered clozapine. What it means is that when we offer clozapine, clients accepted it. It's just a fact that we need to be more proactive in this area. The next one, please. And then the clients undergoing titration in the community, that's again a slow increase in the number of clients being identified for clozapine starts in the community and the number of clients who starts. So there is obviously a gap that we hope we are able to close over the next few months. Next, please. You can see this in 2 different ways, and it depends who you are. You can see the glass as half full or half empty. Next, please. We have made progress. There's no doubt about it. We increase knowledge and confidence in managing treatment-resistant schizophrenia and prescribing clozapine. We increase our quality improvement capacity among our teams, and we have developed tools and resources for the current staff and future staff whenever they want to access it. Next, please. I always like to end with this slide because it really guides a lot of the work that we do. And the biggest room in the world is the room for improvement. I have shown you on the data present that there is room for improvement, and this can be achieved as you continue with your quality improvement journey. And please think about that. Even though we call today the closing Congress, this is not the end. This is only one more step in that journey of quality improvement, particularly the improvement of quality of psychosis care. Next one. Thank you.